As he has just informed you, I'm Parker Emrich, and this is me in front of the Mayo building. I was at the Mayo Clinic Center for Sleep Medicine in Rochester, Minnesota. The Mayo Clinic is a nonprofit worldwide leader in medical care, research, and education. That's their three main values. It has one of the largest sleep facilities in the United States, and I had the opportunity of working there under Dr. Eric St. Louis, who was a very nice man. Unfortunately, he couldn't make it today. Over the course of the summer, this was last summer, we had 4 overall goals. We were doing some analysis of cyclic alternating pattern CAP, non-rapid eye movement, non-REM, sleep patterns in complex sleep apnea syndrome, abbreviated COMPSAS for now and forever. Makes life a lot simpler. And secondarily, we had analysis of REM sleep without atonia, RSWA patterns, and their comorbidity with REM sleep behavior disorder. Tertiarily, we are trying to create better protocols for scoring these two different kinds of sleeping patterns on polysomnographs, because different sleep labs have different montages of specifically what areas of the brain they're monitoring the activity of. The fourth thing is that we were brainstorming preliminary ideas for future research based on sleep deprivation and what we might be able to do with that. For the most part, I'm going to explain one of the 4, because that's a lot simpler for this. Cyclic alternating pattern, CAP, is biphasic periodic activity that occurs during normal non-REM sleep. Phase A is a period of increased cerebral activation. Phase B is deactivation. Our work with CAP was primarily about comparing the abundances of different subtypes of CAP rhythms in patients with COMPSAS. This is a nice example sequence to give you an idea of what it looks like. Here you have an example of the A phase where you've got larger spikes and the frequency is increased compared to the B phase. The 3 subtypes generically are A1, A2, and A3. A1 is seen as sleep promoting, representing the body going back toward deeper sleep. A2 and 3 are kind of arousal promoting. You're waking up and going toward a little bit more of awareness. A1 is primarily synchronized EEGs, where low frequency and high amplitude. A3 is primarily desynchronized, high frequency. A2 is kind of a mixture of the two. Our project outcome, we created an improved set of scoring criteria for RSWA and CAP patterns that they're going to continue using hopefully for years, although I'm sure it will be modified and can change organically as it already was. We created a gold standard, as we called it, for creating inter-rater reliability so that all the different scorers who were doing this would theoretically be able to be producing the same overall results. Likelihood that they would score the same ways, that certain segments would be seen as the same kind of subtype, the same basic duration, etc. We generated preliminary data. We didn't really get too far into analysis of the data on the abundances of different CAP subtypes in the COMPSAS patients. We laid groundwork and created hypotheses and theories for a future study that they'll probably be starting now/next summer on sleep deprivation and its effects on CAP rates, whether or not when people are sleep deprived they have more A1 or more A2 and 3. This is Dr. Eric St. Louis and I next to the founding brothers of the Mayo Clinic. What did I gain from my experiences? Intellectually, I've learned some scoring techniques for RSWA and CAP. Useful and fun. Generally speaking, yeah, I'm sure I'll use this all the time at Cornell, but generally speaking, a deeper understanding of the mechanisms of sleep. We don't know as a society really all that much about why we need it. We know we do, but it's still not terribly understood why. But I got a better understanding of the mechanisms of it and sleep disorders and the psychological effects of sleep deprivation. Professionally, I improved my time management skills and my research skills dramatically. We found a lot of articles, 40-something articles, each person who was working there over like a week. It was intense. I'd never actually lived alone before, and this was a great opportunity to prove to me that I can easily, that it's not really that big of a problem. I normally like having people around. I'm a very social person. It was also a good first full-time job experience in a hospital setting. Like true medicine setting is the thing I hadn't done before in my previous experiences, and this provided that wonderfully. As far as impacts academically, I got to apply the theories and whatnot that we are taught in the biology and psychology courses I've taken here, which is quite a few. It provided an opportunity for guided independent research where I have an interest in ADHD. And as a side project, Dr. Eric St. Louis kind of helped me look through research a bit and find interesting articles that had come out since I had last been looked and do that. It really did also solidify my interest in medicine. Professionally, it provided wonderful first-hand experiences with medical techniques and professionals, and a wonderful panoply of connections were made there. As far as future impact, there was, like living alone, I'd been worried about that being a problem, but this experience really allowed me to see and surpass a lot of my personal limitations, things that I just said I couldn't do years ago, and this allowed me to overcome. It increased my confidence, my intellectual contributions, and my work ethic, and there's a possible future research position with Dr. St. Louis, hopefully this summer. I would like to thank Dr. George Sharp for the donor in honor of Dr. James Culbertson, my site mentor, who unfortunately, as I said, couldn't make it today, Dr. Eric St. Louis, and my faculty sponsor, William Dragon.